Man, you just want a big kiss. Don't you? That's all there is to it.
Thank you.
No, I'm trying to figure these things out.
The Viking cruises are good too for the money, and they're in the ocean now, and so their ocean cruises are great.
Okay.
I would recommend them highly too.
My first choice is going to Eastern Australia.
Mm-hmm.
I've been to Western Australia. No, Western Australia. I've been to Eastern Australia. And I want to see like Perth and this and that, the next thing, everything else. But I'm thinking about maybe putting something else on there.
Crystal goes north, but not that far south to Perth.
Okay.
They go up more like Darwin and across to Indonesia and Bali that way, not clear around. That is off the beaten path. Not very many people go to Perth,
Well,
you know that.
Well, why is that?
And that's why it'd be a cool place to go.
That's what I'm saying.
Yeah,
Exactly
so.
right.
But my guess is, I don't doubt there are cruises, but probably not the major cruise lines.
Yeah.
Did you look at Holland
Seychelles?
America? Yeah, did you look at Holland America? Because they have a lot of cruises in the south.
Yeah, but they all seem more expensive.
We have lots of patients.
Although, you know what, that's a medium price. But, no, you can pay a lot more. Crystal is kind of a little on the above medium range, and then you can pay a ton more on, Seabourn
And that's
some
what
of-
that's why I've never
I'm
heard
very
of
bad
Crystal.
in math,
Because
so
I
maybe less or a little bit
no
more.
one's told me that.
But I don't
we
know.
went
But it's 8 patients.
to the South Pacific for 21 days. Was about
Yeah.
7,500 per person double occupancy, but that was 3 weeks.
That's
I
cheap.
mean, the
I
problem
know.
is that,
Yeah.
Well, of course, I'm not sitting in the best stateroom though either.
Doesn't
I need a view.
It's like an airplane, plane lands at the same time as everybody else does, whether you're in first class or in
That is true.
I mean, it's
So,
like,
let's be
for
honest.
didactics,
Yeah, got to have at least a window. So
My mom initially said something, the internal room,
Actually,
no window.
no window. Yeah,
No.
that would you get claustrophobic. I think. Yeah. I've never done that. I would have at least a window. It's nice to have balconies, and that was the one thing. The Viking all have balconies. Which is
Oh,
nice.
really?
They're not real huge, but you
Doesn't
see
matter.
drive
You can get
by.
out, get a breath
Is
of
that
air.
obvious?
Yeah, I'm saying
Windstar.
because I never thought about
Yeah, those are the
all
big
that
sailing
actually
ships.
came up.
The ones that
They've got some non-sailing ones too.
Yeah.
They're not big.
They're smaller. Have you? Did you do one?
I'm gonna fly in for it.
Now
Did
I
you do a Wednesday? Yeah, no, I haven't
So,
done that.
The first one we did was a three-mast sailor, and they kind of motivated kind of upwind. And then almost the whole week they were sailing.
Do they, on the sailing, how many knots do they go? Do you have a rough
I don't
idea?
know.
You're there being
They
lazy.
turn the motors on if they're behind schedule.
See, on these other cruises, it's mostly, of course, traveling at night, and that's probably true
Yeah,
too.
that's,
You,
but traveling silently at night. Yeah. Thrum of the motor.
although a lot of people like the drone, it's kind of like white noise.
You can see water.
That's true. That's kind of white noise too. That's true. So, there are people that were on our cruise that have been on a Crystal cruise over 300 times.
Really?
You know what? They retired there. They're retirees, and that's their retirement
That's
home.
what they do.
And
Once a year.
what a way to go! It would be awfully pricey, but obviously these people have tons of money. But that would, they just are taken care of. They have the best food, the best booze. A lot of them never get off the boat. I've been there 100 times. I don't need to get off. They just enjoy the ambience of the place.
Yeah.
And it is nice.
Yeah. I've run into that.
Problem is, place to it. There's too much food.
Oh, no question.
Limp state.
Yeah, you know what I do? I would run the deck every day
Stick around.
and to try to burn some of the calories because you do eat very well.
So you have no control.
True.
But it's good.
Yeah, I know it's hard to pass up when it's that good. You're eating beef Wellington and prime rib and lobster and
Yeah.
every
I'm
night.
afraid I'm a little more adventuresome than that. I spent 3 weeks in the Grand Canyon, and that got kind of nasty every now and then.
I did that too, but it
3
wasn't.
weeks?
Well, it was 10 days.
10 days.
We took a helicopter out. You went all the way to Lake Mead, right?
Well, I was in Dory's.
Oh, you were in
The way
Dory.
Powell?
Yeah, we were on a big kind of pontoon boat, held about 20 of us.
That's
Yeah, but true, it isn't the same thing. Although you can get all the water you want. All you have to do is they tie you down in front of the pontoon, let all the water come in your face.
I swear to God, they did that the first time every morning. It was like
To
you
wake
got
you up.
wet
Yeah.
by 10 o'clock.
No, that was a great trip, though. That was that's a bucket list trip. We had a blast.
Absolutely.
On it.
And that's what I'm looking
Spectacular.
for, is those kinds of things.
Yeah, that's spectacular.
Yeah. And so I've been to Eastern Australia. I have not been to Western Australia. And then I've heard you talk all the time about your last trip to
Well, it's off the
Polynesia.
beaten path. If you want to, 3 stops in Borneo. Not too many tourists go to Borneo.
Well, I'm just saying.
And
Yeah.
New
It's not
Caledonia,
interesting.
Solomon Islands, Vanuatu, Fiji. Again, off the beaten path, which was fun. Especially the New Guinea stuff. This
You
is
ever
brand
afraid-
new. Nobody's been going there. It's
You're
rustic.
afraid that you're going to be cannibalized?
We saw cannibals. We saw skulls. Caves full of skulls from cannibals.
Seriously?
Well, it's from the 1800s, but
Yeah,
skulls.
don't kid
Go to
yourself.
Skull Cave. Yeah.
Don't kid yourself.
Yeah, so most of them people come from all over.
So they do the day trips? They're all part
Yeah,
of it?
yeah. Well, no, I guess I should. On Viking, all the day trips are included.
What about Crystal?
Crystal, no. You pay for each one. So we went scuba diving at the Great Barrier Reef. That
You actually
cost an
did
extra
scuba or
$300. Yeah, we did both. Okay. And the snorkeling was great. You didn't have to scuba dive, but that was like to get out there, because it was about a 20-mile run up from the Whitsunday Islands. That was like $300 plus for the day. So you do that adds up
Oh, yeah.
for the two of us. And
Also,
and we did a day trip just about every place. That was one thing nice about Viking. They have good trips that are included. However, like when we were in St. Petersburg, they didn't go to the Hermitage, and if you go to St. Petersburg, you got to go to the Hermitage.
Oh,
So
yeah,
we had to
no
pay for
kidding.
that. So
They did not.
that was what you had to pay for.
It was
They
an
had
add-on.
it. So you could get it.
Oh, yeah, because peanuts, you just have to be careful.
Anyhow,
you
too many good places to go to. Have you done Galapagos?
No, I mean, that's number one on my bucket list.
No, you said you like off the beaten path a little bit more rustic.
Yeah, and I think a lot
Qualifies off the beaten.
And that is paradise there.
And then it's dry.
Good.
But
I
people tell
think
me
generally,
that
the risk of
2 days
systemic
there and
reaction
you're done.
is higher.
It's only a postage stamp. I haven't been there, so I can't speak to it. Obviously we want to see those monoliths out
It'll
there.
take a while to get there.
Yeah,
Easter Islands, though.
it's off Chile,
Or Antarctica.
It's
Yeah.
chilly.
Unless you're,
It's off the coast of Chile.
Antarctica, see some
because I think
penguins.
there are like rare.
Yes. Oh, I want to go to Antarctica. Right at the top of my
Understand,
list.
they just think. You know they're there before you know they're there.
I was like just.
The Galapagos have penguins. Here they're on the equator.
Yeah.
They're so bizarre that
Yeah, we tried to see a lot of them when we were in Eastern Australia, but we never got to see it.
In the middle of the street parking down there.
Bucket list.
Unless they keep.
Yeah, no, I want to too. They have the Northwest Passage now. You can go
Yes.
all the way through. I want to do that one. But that's a long one.
Why?
It's just incredible scenery. I want to see the narwhals and beluga whales and the muskox and polar bears. And
Before it's open for drilling, right? Go there now.
Buy a few lots.
Yeah, but
And say let's drill.
I'm a nature lover. Actually, favorite single destination area is Sub-Saharan Africa. You've done it?
No, I've not done that because I'm comfortable.
I thought that's what you wanted. Adventure.
You know what I'm saying? There's adventure and there's uncomfortable.
Yeah. Once you get out of the cities, you're fine. But in the cities, it can be rough. You don't go out at night, that kind of thing.
Okay.
But I would recommend it.
Camaradas.
Say again?
Camaradas.
Oh, I don't. Is that what that is? I didn't know it was an airline. So.
Yeah.
that's the Saudi airline.
Yeah.
Oh, is that right?
What is that?
Did you fly to the Middle East? Have you done it yet?
It's interesting you know that. So yeah.
One of my patients, She and her husband do a lot of traveling, and they rented a suite on
Morning.
the
I'm
A
heading
suite?
south.
Oh, God.
So
Yeah,
they
you're
have
better
a
than
full
us.
size
California.
bed,
That's beyond
shower,
too cold. Yeah, I mean, I'm
All
talking
sorts of ice off
kind of
the
business
California.
class at the
She did. I
most.
was
She
just
showed me
in
pictures of her room on the
Carmel.
airport.
Yeah.
It's like
We were down on the beach. It
Yeah.
was in the
College dorm
60s and the flowers were
Yeah, I'm gonna just get my plane and
two like 30 million people live in
They know how to
Yes.
travel. You know, I went, when I went to Australia, I went over on Korean Air. Fantastic. Unbelievable. Spent a couple days in Seoul. And then went down.
guy.
Came back on United.
My second then.
It was like, business class was the second class. It was totally different. No question.
Well, my son-in-law, his dad is immigrated from South Africa, so he
Oh,
and
really?
my daughter spent
It's at like
3 weeks in South Africa a couple of years ago.
it's at
Yeah, they had some pretty interesting stories. They flew to Amsterdam and got away from Amsterdam to Wales or to Cape Town.
Present Journal.
And, you know, it's the cities. Cape Town's actually really nice. Johannesburg is not so nice.
I'm not much of a scientist.
Try it someplace. Try it. I spent a lot of time in Europe, no question about
Or they
it.
send you a reminder
A lot of time.
on Friday saying you're sliding.
I was like, you sent me that one.
Have you done another Viking River cruise?
I had one from
No, but my wife has.
this year. She's going to have some new information on it from the other.
I've been to
The other
those
one didn't
different
go into
cities.
vitamin D
Just
levels
out
at all.
business.
One of my friends went and did that. They had a
Well,
bicycle.
I looked at it.
So every
No,
day,
you know, I did
you get
look
breakfast on
at
the
it.
boat,
And I
Then
probably
they pack
should
you
have
a
talked
lunch.
about his son, but
and you went on a
I didn't say it
bicycle
right
and you
away.
rode about 20 or 30 kilometers and you met the boat for dinner.
do I need to
So you had
sign
to
in
get out
in
and
about
come
6
back.
minutes?
Oh, that sounds fantastic.
Yeah, and then every day they did the same thing. They had a blast.
Yeah. No, I've been to all those cities. At different times. I had to go over there a couple times because I was with, I want to say Bear, but not U.S. Bear. It was Bear at that time. Sharing AG. And, so it'd be across the U.S. or across, Europe. England, Scotland, this, that, Berlin, Switzerland, and those kinds of places. But I want to go somewhere. I just really want to have another adventure.
Well, you go to Easter Island, that'll be
I think there are other places. That seems remarkably remote.
Yeah, you might as well go to Antarctica. You're only a little bit of a
Yeah,
trip
what
away.
difference does it make? But I think Scotland is a better place. Yeah, or,
And it's like, I know, but sometimes what happens is that they microwave
Somewhere in
it, they
Asia.
don't use it, so they microwave it.
how you doing, sir?
I can't find that.
Oh, gosh. I'm ready
I
for
can
some
What is that? What does that
warm
mean?
weather. My car was iced over.
Yeah, mine was too. Mine was too. I went back in the house and got a thing of hot
Water
water.
was soaking in.
It is the solution.
She said you wanted to see her when she flared up and she called it a good
Yeah.
culture. Right now, my ears are frozen.
I know.
And all her kids are IJ.
That was good. How many years ago?
I think she's plugged in. If not, I usually get them.
I've been there.
No.
Anyway, by cultured, I wasn't sure whether you wanted to culture bronchoscopically or you wanted to culture
Yeah, and this,
I believe it was sinuses. I haven't seen
after
her.
that,
It's been.
Yeah, she's been hardly IG.
I know. I remember her now.
same when you
Golf.
She's kind of one of the right on the borderline.
Yeah.
She swears that she does. She feels like she does a lot better, but.
That's the biggest thing. We always wanted to be spoiled. Yeah.
Yeah, she's got some other issues. I cultured her right side, so.
Yeah, you let me know if anything grows
I
out.
will.
Thank you.
I just want to make sure that's what you want.
No, that is what I want.
Okay.
And the stroke
Bad?
right side, can't talk.
Sorry.
So that's the.
Yeah, that keeps you busy.
About 2 weeks ago, I inadvertently picked that up.
Dr. Mike, how's your,
Yes.
It's cold. He's heading for the
Cold.
sun.
I'm
He said,
heading
"Are you
for-
really?"
I'm going, yeah, I'm gonna go Friday.
Go
We're gonna
where?
drive the Tesla
Are you,
down.
one of
to-
your kids down there?
Yeah, Ryan lives in San Jose, just outside of San Jose.
Santa
And Haley's lives in Los Gatos. So 2 out of 4 kids there.
So you're gonna go free load off your kids just because it's warm?
Yes. Play golf in warm weather. And
Nice. Do they play golf at least with you?
Ryan does. He's quite a golfer, actually. He took it up young and
My patient's son is either a freshman or sophomore in high school. He's scratching.
All right, let's,
One kid gets on
so
You gotta
go
start
ahead and
early.
get started. So this is the reason that this has traditionally been called Journal Club. We've reduced it now to maybe about 4 sessions a year where we actually review journals. And usually we get a lot of information in a short period of time. Where are the second-year fellows? No one knows.
I'm working on journals.
Just one comment. I'm going to be out of town, but next week Alan Kaplan is the speaker, and he's one of the more prominent people in American allergy. Basically, his career has been urticaria, so he's one of the national experts. And for urticaria, I encourage a good turnout. We've never invited him to Seattle before, so I'm happy that he's here. So both for our virtual audience and our in-room audience, it'd be nice to have a good turnout for him. So today the day of the word is allergy. We have, I think, a couple of late additions. One for sure that didn't get sent out yesterday, some additional articles. Gary's going to start off with a broad review of, you can see, vitamin D deficiency and extraskeletal disease. I think it's entitled Causative or Innocent.
Actually, I started this subject about 2 years ago, but fortunately for you guys, I got bumped by an outside speaker. I decided to go over it again because obviously a lot of docs jumped on the bandwagon about using vitamin D, and understandably so, because observational studies had showed that low vitamin D levels were almost universal on almost all illnesses, so it sounded like panacea for a lot of problems. So I wanted to review the data. The other thing I want to point out is that, of course, all the observational studies have supported the fact that low vitamin D may be causative. You really need to do blinded controlled trials, and that's what I'm going to focus on to show whether really there is a difference or not, whether you treat it. Now, I have my disclosures. First, I do not take vitamin D. Do most of you take vitamin D?
Yep.
All right.
Yep.
But I do eat a lot of fortified ice cream. As shown in this picture, I put it up there to embarrass my son. I often overdose on the sunshine vitamin, and there I am in the lower corner on your left with a control subject compared to the sunshine vitamin that I have on my face. Did I embarrass you, Drew?
Thank you.
By the way, this is in Len's backyard in Kauai. It's a very nice place to go. So by the pool. Now, there have been multiple medical fads and controversies over the year, and this is a little bit of history, especially for the older guys in the room that have lived through this. Back in the 70s in medical school and early residency, hypoglycemia was used to explain chronic fatigue and almost all ailments that known to mankind. And in the early 80s, chronic EBV was felt to be a cause of chronic fatigue based on serologies that showed they had antibodies, but as you know, everybody has antibodies to it. Now, I don't know how much the fellows know about multiple chemical sensitivity syndrome. Have you heard of it? So that shows you how young they are. This is a huge deal from the 1970s into the 2000s. This lost a lot of steam. And this is the concept that low-level, everyday chemicals in life cause all ailments known to mankind. Kind of a fallout from this was the toxic molds, and a lot of people jumped on that bandwagon, even people in the allergy community, that low-level toxins in especially Stachybotrys, the black mold, was the cause of multiple ailments. And if you go on the internet and look up toxic molds, you don't get to a medical site, you get to a lawyer's office. But that's pretty much fallen by the wayside too, especially because of physician statements by the American Academy of Allergy.
Still a lot of litigation, though.
Oh, the litigation, and it's good for business if you get into that area. Are you still doing it, Lane?
Occasionally.
Yeah, I still do something. In the late 80s, into the 90s, popular belief promoted by a physician from the Mayo Clinic, Ponytow, was that fungus was the cause of almost all rhinosinusitis or chronic nasal symptoms. And that was based on the fact that for almost all these patients, you could culture molds out of their nasal secretions. The only thing the guy overlooked was that in normal people, almost everybody grows some out. Anyhow, that has kind of fallen by the wayside, but I think some of the ear, nose, throat guys are still irrigating with amphotericin still. In the infectious disease literature, I don't think it's a concern of the people that practice infectious disease, but there are certainly lots of lay public people that believe that there's such a thing as chronic Lyme disease, which clearly infectious disease societies don't believe. Now, a couple of years ago, I did a discussion on the occult gastroesophageal reflux as a cause of chronic cough, exacerbation of asthma, and chronic laryngitis, and that's a common belief. But the truth of the matter is, you look at the controlled trials, the double-blind placebo use of medicines to treat acid reflux, you cannot show an association. A big thing right now, of course, and all of us have to deal with it, but it's good for business, is everybody thinks they have wheat allergy or wheat intolerance, so I do a lot more skin testing for foods than I ever did in the past, just to show them that they didn't have any allergy to wheat. I think that MCAS is kind of in this same ballpark too, mast cell activation syndrome. I think a lot of people have a little bit of itching, but a lot of the somatoform disorder type complaints are jumping on this bandwagon. I know Drew has been getting tired of seeing them. Are the rest of you seeing them? The other thing, I don't know, if somebody's going to help me out on this whole thing about POTS disease and how much of this is real. Does anybody have a feel for that? MCAS and POTS are all often being labeled together. So, anyhow, those are some of the fads and controversies over the year. The one I decided to pick up was how much is vitamin D deficiency really a cause, evidenced by controlled trials with treatment of non-bone diseases.
You didn't comment on the picture.
Oh, you know what? I was looking at fads, and that was just a picture that came up. I don't know. That's a specific treatment. It's a little bit like cupping, and I have patients come in with a cupping all the time, especially Southeast Asian.
That's a snail.
Anyhow, here are actually not a complete list, but a significant list of all the conditions that have been associated with low vitamin D levels. Obviously, osteoporosis and osteopenia. But for the non-skeletal things, 17 varieties of cancer, heart disease, high blood pressure, obesity, and you can read this with me, autoimmune diseases, multiple sclerosis, rheumatoid arthritis, falling in the elderly, you keep going, gout, infertility, importantly, depression and seasonal affective disorder, Alzheimer's disease, chronic fatigue syndrome, fibromyalgia, and at the end here, and I'm going to talk a bit about it, about asthma and COPD as well has been associated with low vitamin D levels. So again, just about every disease you can think of is on that list that has been shown by observational studies to have low vitamin D levels. Now, the big thing is it causing the disease or is it an epiphenomenon? Anyhow, about 2 years ago or 3 now, I looked at this as I told you before that I was going to do this talk last year. Anyhow, there was an umbrella review they call it the meta-analysis of observational and randomized trials in the British Medical Journal in 2014. And in addition to the observational trials, they tried to correlate it with a randomized trial of vitamin D supplementation for these syndromes. The results were huge, this study. 107 systematic reviews, 74 meta-analysis of vitamin D, and 87 randomized controlled trials of supplementation. Now, I put this up. Obviously, you probably can't read it, but it's just for effect. And is a forest plot, and to the other side of the null line are all the diseases that basically show by observational studies an association. Can you even read those?
A little bit.
But the point is that almost all the, most of them, or many of them, have been associated, and at the top are mostly cancer ones, cardiovascular disease, again, is the one listed before, hypertension, stroke, Alzheimer's, depression, metabolic syndrome. But again, these are observational studies. So clearly there is a strong association with many diseases of low vitamin D levels. Now, the fallout from this is based on observational studies, we got a lot of advertising to us saying that vitamin D deficiency was the cause of all these diseases without doing the appropriate trials. So these are the things you see for the lay public. These ads like reduce your risk of flu, decrease cancer, muscle aches, cardiovascular disease, depression, diabetes, autoimmune disease. You go over to the right, the picture on your right-hand side, you know, you're more likely to have depression. It decreases your risk of breast cancer by 83%, they made the claim there. And 60% of vitamin D are people with fibromyalgia, low vitamin D. In other words, this is all based on observational studies. Now, it actually makes some sense to be concerned that low vitamin D levels may be having an effect on all these other diseases, because the vitamin D metabolism involves almost all the cells in the body. Vitamin D receptor is essentially on almost all nucleated cells. There are 10 tissues other than the kidney that express the enzyme to convert the vitamin D to the 125 vitamin D, or the active hormone. 37 different tissues express the vitamin D receptor. And obviously, binding to all these other tissues that are non-bone, it suggests that the spectrum of vitamin D endocrine system is broader than just calcium and bone homeostasis. So there is a good reason to be suspicious that it could be playing a role. Now, this is just a busy slide just showing how involved vitamin D is in overall metabolism in the human body. But the only reason I put the slide up is down in the lower left there. It has vitamin D receptors in the brain, muscle, heart, pancreas. It has an input into the immune system, etc. So it does have the potential to affect many bodily systems with the treatment of vitamin D. Now, just some basic physiology. When you measure a vitamin D level, you're measuring the 25-hydroxy vitamin D3, and that is a fairly representative body levels. You know, the active hormone is actually the 125, produced by the kidney, but this is in 1,000th the level of the vitamin D3 in the blood, and it's very volatile, so it can go up and down for various reasons. It may not be representative. A definition of low vitamin D is less than 20 nanograms, which is the same as 50 millimoles. You're deficient if you're between 20 and 30 nanograms per mil, and then above that it's felt to be normal. Just a comment on vitamin D2, which is ergocalciferol. It is not very effective, and it is not recommended to use that source of vitamin D for treatment as opposed to vitamin D3 or cholecalciferol. At any rate, the slide does show that you can make all the vitamin D you want if you get out in the sun a lot. You don't need to take it in your diet if you get in the sun, but obviously a lot of us are avoiding sunlight because we're worried about cancer, plus we're in a cloudy climate. So anyhow, you can get it from milk and food products, of course, and then the vitamin D is converted in the liver to the 25-hydroxy, and then the kidney produces the 125. Now, based on these assumptions about basic levels, it showed that 30 to 50% of people in USA and Northern Europe are deficient, so that means just about everybody is. And they said that 82% of critically ill people have low vitamin D. Now, what do the trials show when you do randomization of supplementation of vitamin D? And again, in numerous studies, it's basically the same slide as before. And here are meta-analysis of randomized controlled trials of vitamin D. And this is from the British Medical Journal article I was talking about in 2014. The upshot, let me look at my cheat sheet here, because you can't see the darn slide, is that the only things that were correlated that responded to treatment are low birth weight, hypercalcemia in those with chronic kidney disease, and this is an important one, dental caries in kids, so I don't want to badmouth vitamin D completely. So on the other hand, for almost all the other conditions, heart, cancer, etc., there was no evidence when you almost all crossed the null line. So we're not statistically significant. In this particular study, it did not show a decrease in all-cause mortality. However, in another study from the British Medical Journal that same year, the study that had more patients involved that did. Let me jump to that. Let me summarize that slide I just showed because I got these out of order. Here's the summary from the 2014 review. It said, this umbrella review collectively presents the evidence from systematic reviews and meta-analysis of observational and randomized controlled trials in regard to 137 outcomes. The only associations with vitamin D concentrations in treatment were birth weight, dental caries in children, maternal vitamin D concentrations at term, parathyroid concentrations at kidney disease. So in other words, for almost all those diseases, they could not find any clear-cut evidence of treatment, despite the observational studies. In contrast to previous reports, and this wasn't addressed on that slide I showed you, these findings cast doubt on the effectiveness of vitamin D-only supplementation for prevention of osteoporosis and falls. It should be added, even those with osteoporosis that take vitamin D, there's no evidence that there's no compelling evidence, I should say, that vitamin D can treat osteoporosis by itself without calcium, and it does not decrease fractures. So it's bone metabolism is much more complicated than just vitamin D. Anyhow, their summary statement of this review highlights the absence of meta-analysis in relationship to autoimmune disease and cancer, cognitive, and infectious disease outcomes. Now I got that out of order there. However, from the British Medical Journal, and this may be a reason to still consider using vitamin D, is that in a larger meta-analysis, they looked at all-cause mortality using vitamin D3. It should be noted that vitamin D was not, vitamin D2, is ergocalciferol was not affected, by the way. Anyhow, they looked at 42 double-blind placebo-controlled trials, about 85,000 patients. The average study was for 4.5 years, and what they did show that there was a slight decrease in all-cause mortality, and that for every 150 people treated 5 years, one life was saved, but it had to be more than 3 years. The upper part shows 3-year studies, which were not significant, less than 3 years. The bottom one does show statistical significance if it's more than 3 years. So it was a modest decrease, but there was statistically significant decrease in all cause mortality. And then the summary from that article said, in conclusions, our results show that long-term supplementation of vitamin D may have beneficial effects on overall mortality, especially in patients with vitamin D insufficiency and patients younger than 80. They recommended the optimal dose is 800, not more, and that they said future studies are needed to determine efficacy in other conditions. Now, since those studies, there's been some information on looking at asthma that weren't included in that British Medical Journal study. There were a recent, this is from 2016, there was a Cochrane review of vitamin D for asthma, which included 7 double-blind placebo-controlled trials with roughly 1,000 patients, and mostly with moderate asthma. The study went for 6 to 12 months. In the Cochrane review, they did not measure vitamin D levels, but there was a subsequent one last year, and I'll briefly allude to it, that did. The results were that it showed that it decreased exacerbations requiring steroids. It didn't decrease exacerbations, but it did increase exacerbations requiring steroids from 0.44 to 0.28 per person per year, which is significant. Emergency room visits were decreased from 6% to 3%. It did say that there was no change in lung function or day-to-day asthma symptoms. A criticism of the studies, they did not have a severe asthma. Now, Len sent me a study that just came out last month that did look at vitamin D levels, and they got almost the same results as this. I don't know if they used the same studies, and I didn't go back to check. But it's interesting, the ones that were helped were the ones that had low vitamin D levels, whereas the ones that did not have low vitamin D did not respond to this in the study. The other thing, it showed that it was the blacks and women responded, but men did not respond in a statistically significant way to vitamin D. So there still needs to be a lot more study to look at what role this is, but it's an encouraging study that suggests that we may be using vitamin D for asthma. There's also some recent articles on JAMA in 2016 looking at vitamin D and pregnancy and the risk of asthma in children looking after 3 years. And in the first one, it said that in the trial there were 623 women randomized to 2,400 versus 400. 400 international units is what's in all the vitamin pills that you always give your pregnant women. And it started at 6 months of gestation. The second study started at 10 to 18 weeks. But they followed the offspring to 3 years of age, and asthma or recurrent wheezing at 3 years of age was 16% of the vitamin D and 20% placebo. Not statistically significant, but a trend. It said, furthermore, but there was no change in lower respiratory infections, in allergic sensitization, or in eczema with the vitamin D treatment. A similar study looking at 876 women randomized to 4,400 international units versus 400 started 10 to 18 weeks. And they also saw a trend, but not statistically significant. Asthma or recurrent wheeze was 24.3% at 3 years of age in the treated versus 30.4% in those not treated. There was a study on vitamin D and COPD, and they gave vitamin D3 supplementation in patients with COPD. They were looking for prevention of a first exacerbation or first URI, thinking it would affect infectious disease issues, but there was no difference. However, they commented in subgroup analysis that vitamin D less than 15 nanomoles per liter, or deficient by the usual definition, protected against severe exacerbations. I did not go back to see what that meant. Now, this is just a study you're saying, well, I think I'm just going to take vitamin D just to improve my bone density. This looked at normal, young children and adults, studying from 3 months to 4 or 5 years. And the upshot, if you look at the diamond here.
At the bottom?
Yeah. Anyhow, I can't find it. Okay. Oh, there it is. You look at the bottom, the diamonds are the summary of each of these, of the forest plots. The upshot is it doesn't do anything for bone density. Okay, so it doesn't make any difference in, these are all comers, these are people who probably have vitamin D deficiency and don't. But again, supplementation with vitamin D doesn't do anything. So in summary, there is a lack of concordance between observational studies and blinded trials. Randomized controlled studies of vitamin D supplementation have been, for the most part, disappointing. Enthusiasm for vitamin D therapy outpaces the evidence. Routine serum vitamin D testing or screening for vitamin D deficiency is not recommended. Routine serum vitamin D testing after supplementation is not recommended. And if you're going to treat them, the dose should be 400 to 800 units. There is no good evidence that higher doses are of value. In fact, they may be harmful. Very low vitamin D levels, however, like people that have severe levels, have rickets and the like. That may is a different population, and of course that may be an exception. As far as the statements regarding organizations that review this kind of stuff, some of the comments are the USPSTF concludes that evidence of screening for vitamin D to improve health outcomes is insufficient, and the balance and benefits and harms of screening and early intervention cannot be determined. The Endocrine Society said, we do not recommend population screening for vitamin D deficiency in individuals who are not at risk, and the British Medical Columbia Service Commission said the same. Skip that. Here's up to date, was just from last month. Here's their summary statement. There are no convincing randomized trial data that vitamin D supplements can decrease cancer risk or prognosis, decrease the risk or severity of infections or autoimmune diseases, or decrease cardiovascular or metabolic diseases. There are no prospective studies to define optimal vitamin D levels for extraskeletal health. Therefore, we do not suggest vitamin D supplementation. What is required for osteoporosis. This one, the other study said that there was little evidence to suggest it decreases falls. On this review, they thought there was. So basically, that's the summary of the studies. And so I think it's still up in the air whether we should be measuring vitamin D levels. Have you checked your own vitamin D levels? Good. They're probably low.
She lives here.
So anyhow, that's basically the summary, and I'll skip the last slide. So any questions? Lennon, you still taking your vitamin D?
Yeah, I still take vitamin D.
But you know what? Like I said,
The question is, what's the harm?
well, that's a good question. You know, you can't get hypercalcemia if you took too much. And I think that's the one statement. It's harmless, I think, for the most part, as long as you don't take too high doses.
So a couple of years ago, and actually later, you know, Ray Panettiere was a big advocate of this. So he's a prominent pulmonologist, was at Penn, now at Rutgers, and we have him coming later in the year. So the last time we had him here, he was recommending for asthma patients 50,000 units a week.
And it somehow changed the steroid receptor or something.
Huh?
And it did something to the steroid receptor in the
Right,
asthma.
and so it'd be interesting to see if he's still advocating that and if he's got a justifiable argument for it. So let's remember to ask him that when he comes. I don't have the calendar in front of me, but
Well, he did jump on the bandwagon before the studies, is the thing. He was early on in that. So.
he's also big into bronchial thermoplasty. So we could talk about. But all right, so let's come back to that later in the year. Okay, so Jamie is next, and then Matt.
So, the first article I'm going to look at is looking at penicillin allergy testing in children with low risk symptoms. So any disclosures. So background information, so up to 10% of the population are labeled as penicillin allergic, but more than 90% of patients with a history of reported penicillin allergy can actually tolerate penicillins. And labeling a penicillin allergy has implications, as we all know, so broader antibiotic coverage, higher costs for more expensive medications, prolonged hospitalizations, and increased risk of antibiotic-resistant organisms. So there are a few studies looking at penicillin testing in children with low-risk symptoms, but I'm focusing on one particular article today from this year in Pediatrics. So it was done at the Medical College of Wisconsin. It enrolled children presenting to their emergency department between April 2015 and November 2016. They initially enrolled children ages 2.5 to 18 years with a history of reported penicillin allergy, and they gave parents a questionnaire about the penicillin allergy, asking a number of different questions. The article didn't actually say the questionnaire, so I don't know exactly what the questions were, but they asked things like how old the child was when they received the penicillin, what the reactions were, why they received the penicillin, things like that. So this is their table of characteristics of the participants.
So the average age of the children were around 9, but they were about 1 when they had their allergy diagnosis. Most of the patients were white, almost 60%, followed by African American, 20%. And then, so to be eligible for the allergy testing, the child had to be over 4 years of old and be deemed low risk. And low risk included rash, itching, diarrhea, GI symptoms, family history of penicillin allergy, and then some other sort of non-specific symptoms. Interestingly, they didn't mention anything about timing between when patients got the penicillin and when the reaction started, which has been looked in some other studies. And then high risk included any respiratory complaints, wheezing, hypotension, syncope, severe cutaneous involvement, which they said they included angioedema, blistering rash, or diffuse erythema, or anaphylaxis. And then if the parents were interested in allergy testing and they were deemed to be in this low-risk category, they confirmed through the medical chart and then also called the pediatricians to just confirm the reaction and that it was low risk. And then patients who met criteria were asked to return for 3-step allergy testing. So they didn't do it in the emergency department when the kids originally presented. They had them come back later.
They have their rationale why they wouldn't test high risk. I mean, the implicit would be that it's dangerous.
Yeah, they did not say that. And it's interesting because they weren't just going straight to an oral challenge. They were testing. So, you could skin test high-risk patients. So they didn't mention that. And there was no control group. They just looked at the low risk. So this is just a breakdown of the symptoms. They were not mutually exclusive, so it doesn't add up to 100%. But many of the patients had rash, itching, some were hives, some were non-hive rash, and then some other non-specific symptoms, diarrhea, vomiting, runny nose, cough, things like that. And then this was the list of the indication for the antibiotic initially when the kids received it. So most of the kids had ear infection, followed by throat infection, and then some other infections. So they initially approached almost 800 patients in the emergency department for the survey, and then almost 600 patients completed the survey. And then out of that, they deemed that 430 were low risk and 163 were high risk. Interestingly, out of the 163 high risk patients, 128 were interested in allergy testing, but they didn't include those patients. They didn't actually test them. And then out of the 430 low-risk patients, 352 were interested in allergy testing. And out of those, 47 were ineligible by chart review. 8 of those were because of age. I'm assuming because they were between the ages of 2.5 and 4. And I'm not sure why they said they approached kids at from 2.5 and above, but they only did testing in age 4. I'm not sure why they didn't just approach kids 4 and above if that was who they were going to test. And then 39 patients they excluded by medical history. And again, I'm sort of assuming that the medical history implied a more severe reaction than the parents reported, and they were able to corroborate that. But they didn't specify. And then out of the patients interested in allergy testing, 300 of them were eligible by chart review. And almost all of those, so 302 were eligible after PCP contact. So most of there were only 3 that the PCP presumably said that the reaction was more severe than the patient's parents stated. So out of the 300 patients who were eligible for the allergy testing, they only tested 100 of these. And they didn't have a really great rationale for that. They just said it was for convenience. And I'm not sure how they picked the 100 out of the 300 patients, whether it was random or not. They didn't say that either. So then they had them come back, and they did sort of standard pinprick testing, followed by intradermal tests. They had either immunology allergy fellows or emergency medicine fellows do the testing, which was interesting. And then they defined positive, sort of standard, if wheel diameter was greater than 3 millimeters above the negative control. And then interestingly, they said if there was a positive reaction, they still allowed children to continue with the graded oral challenge. And the oral challenge was 500 milligrams of PO oral amoxicillin tablet or 520 milligrams liquid amoxicillin. And so there were 3 children who were positive on skin testing, and they had a little table just talking about the children. So the first child tested positive to both the pre-pen and penicillin G. And they said that the child was retested on a later date and had negative percutaneous, intracutaneous, and then subsequently oral challenge results. They had sort of similar things for child 2 and child 3. So child 2 also had positive penicillin G testing, and then again they said was retested at a later date and had negative skin testing and an oral challenge in the table. Child 3 is basically the same story. This was a little bit interesting because they didn't, in their methods, they said that if they were positive, they would continue with their oral challenge, but they didn't say anything about retesting them. And it wasn't clear to me whether they, like the time frame when they retested them, and whether that they even retested them or they were retested by someone else at a later date. They didn't really specify that. So overall, 3 of the children, as I mentioned, had positive skin testing, but all 3 of those still passed the oral challenge. And so overall, 100% or 100 out of the 100 passed the oral amoxicillin challenge. So I think,
Just ask one
yeah.
more about- So it looks like all 3 were positive to penicillin more
Yes.
so than pre-pen, which in my mind is just a false positive because of the irritative effects of penicillin, and it makes me wonder why we just test with it anymore rather than just pre-pen. Nobody's allergic to.
Why do you say that, Matt? So, I mean, usually we use Pen G to be, quotes, the minor determinant.
Right, which it's not, and you know,
It's a
I'm not aware of
technicality.
I'm not aware of anybody who's allergic. I mean, penicillin is allergic only because of its ability to act as a hapten and conjugated endogenous protein, right? Which doesn't happen in the skin test with penicillin G. So, and plus here, I mean, they just proved that the kids who were positive to it and were negative to oral challenge.
I mean, the first child they said was, just to point out,
that one
positive
did
to
say
both
I
pre-pen and penicillin.
But that whole part of the study's ridiculous. If you think the skin testing is diagnostic, why would you then give them an oral challenge? That's not what
Well,
we're
and
doing.
that's what I'm saying, that in this population, they just had a couple of false positives to PEG, probably because it was placed inappropriately. And, you know, my point would just be you have to be very cautious about interpreting a PEG skin test as opposed to a pre-pen skin test.
What are you using for a minor determinant at the
We
university?
use it, if it's positive, I just place it again and show that it's negative the second time.
I mean, do you have a minor determinant test here at the U?
No, there isn't.
There was
What's the rest
also-
of the community doing?
There was also a study a few years ago that using PenG 10,000 units for the final concentration is much more irritating and can cause false positives. So they need to use 6,000. So we started using 6,000 at Montefiore because of the amount of false positives that we saw and because of that study. So this
As opposed to which those?
10,000
I mean, we usually use 1,000, don't we,
for
Frank?
final. For final
We
concentration.
tested
5,000.
5,000?
We still use 10,000 here.
Yeah, so I mean, I just ignore it. If it's positive, I repeat it until it's negative.
Yeah, I just challenge it.
Pre-pen is
It's just
different.
Pen G.
If pre-pen is positive, that's real. So that's
Well, the problem is the old literature said that the most severe anaphylactic reactions were mostly diagnostic with minor determinant testing. So we have no accurate way of testing for minor determinants. This is pretty bold, just giving people the drug. I mean, why bother to test? Just give them the drug and deal with anaphylaxis.
Well, but I mean, here the problem is they screened out all the patients who would actually be.
Yeah, this was illogical. The people who should have been tested were screened out, and they were afraid to test them.
But it goes to show that in people who are low risk, if you're going to test with PEG, frankly, you should ignore it. Isn't there a plan? Didn't we have somebody here a year or two ago who said minor determinant? Somebody's working on a commercial version of it.
We used to have it.
But somebody was
15 years ago, we had minor determinant mixture, and then they took it off the market.
Yeah, the same company that makes Pre-Pen, I think, was working on it. I don't know what happens.
And the NIH is trying to underwrite
we actually
it
have
as like an orphan drug project because it's needed.
I mean, we make sodium penicillin, which we've tested for years. The irony of it is that we don't test the high-risk patients, though. I have never seen a positive, you know, I mean, to the point, but these are not high-risk patients that we test most of the time. So.
But I think that there was a few years ago they said that there's no need to test for all the minor determinants just because the difference is not much just by doing
Statistically.
statistically.
Yeah, right.
Yeah.
There's a more recent one, yeah, that's an effect of that. Like if they're negative to Pre-Pen and they do react, it's actually going to be a minor reaction. The other thing I'll usually test to is because there are a lot of reports of side chain reactions to the amino, so testing the ampicillin as well. If there's any concern for being.
Actually, I was just going to ask about. I had a woman just the other day who only reacted to amoxicillin. And
That's pretty common.
yeah, I used to be skeptical that were just side chain reactions, but there are.
Well, and then there were case reports of clavulanate being an issue in some patients too, which I've not seen.
50%.
Versus plain amoxicillin.
So here at the U, I mean, the group that this was pediatrics, but I mean, the people who most needed to be tested weren't tested in this study. So how is that handled here in particular if you're really concerned about a serious reaction?
Well, if we're concerned, we'll just do a
Yeah, I
desensitization.
was going to say.
But there was a large study from Harvard 2 years ago. One of my friends did it actually, and that showed that you don't have to skin test low-risk patients. You can directly challenge them. That was chosen as one of the best articles in the conference also. So they hardly saw any severe reactions when they challenged patients with which is the case. So yeah, this supports that as well.
Yeah, I think you guys mentioned a lot of things to talk about. I mean, overall, I don't think this was a particularly well done study, and they did screen out a lot of the patients that, the high risk patients to sort of compare to. But I think the point was they were trying to see whether low risk patients you could just sort of give them amoxicillin and just bypass the skin testing. But they did say that even though all the patients here pass the oral challenge, this study was not sufficiently powered to make the conclusion about the ability to bypass skin testing. So, and there are other studies sort of supporting that you can do it. I just don't know that this study was the best one. So my other article. So I was looking at this study looking at Icatibant for ACE inhibitor-induced angioedema. That just came out. So some background. So ACE inhibitor-induced angioedema may account for up to 30% of all cases of angioedema that's seen in emergency departments. And it may occur either early in treatment or even after several years of being on an ACE inhibitor. ACE inhibitors inhibit the breakdown of bradykinin, and that's thought to be sort of the main pathophysiology, but it's suggested that there may be other mediators involved as well. And Icatibant is a selective bradykinin receptor antagonist. So just to kind of review, ACE inhibitors here in red prevent the breakdown of bradykinin. And Icatibant is sort of lower in the pathway, and so presumably if that is the sort of main mechanism, there's a possibility that it may work in ACE inhibitor-induced angioedema. There was a prior phase 2 randomized double-blind study that did show faster resolution of symptoms in ACE inhibitor-induced angioedema, upper airway angioedema, patients receiving Icatibant compared to patients receiving steroids and antihistamines. The goal of this study was to look at whether Icatibant was helpful with regards to resolution of symptoms in ACE inhibitor-induced angioedema of moderate severity. It was a phase 3 randomized double-blind clinical trial at 59 centers. Most of the sites were in the U.S., but there were some abroad as well. They enrolled adults who were on an ACE inhibitor and presented with angioedema of just the head or neck that had been present for less than 12 hours and were of moderately severe symptoms. They excluded basically patients who they thought had a reason to believe the angioedema was not from the ACE inhibitor, so family history of angioedema, personal history of angioedema prior to starting the ACE inhibitor, and then some other things that could have potentially explained the swelling, like anaphylaxis or an infection in the area, trauma, post-operative edema, urticaria, to suggest maybe it was histamine-related instead, or severe angioedema requiring immediate intubation. And they said that was mostly because the patients couldn't obviously consent to enrolling in the study if the patients were intubated. So they allowed patients to receive antihistamine steroids or epi at any time, either before or after Icatibant or placebo administration. And then patients were assigned either to Icatibant 30 milligrams or placebo as a single subcutaneous dose. They enrolled 121 subjects, and half of them were assigned to Icatibant and half were assigned to placebo. And then a physician who was blinded to what the patients received assessed the severity of their symptoms based on 4 categories. So difficulty breathing, difficulty swallowing, voice changes, or tongue swelling. At baseline, at 30 minutes, 60 minutes, and then hourly until 8 hours, then every 2 hours for 24 hours, and then after that every 3 hours. And just to mention, so the categories were rated from 0 to 4. 0 was no symptoms, 1 was mild symptoms, 2 were moderate symptoms. They didn't say, but I'm assuming 3 and 4 were severe symptoms. And I think that was just based on the physicians, whether they felt how severe the symptoms were. So they had 2 endpoints. The primary endpoint was time to meeting hospital discharge criteria, which they defined as having a rating of 0 basically on difficulty breathing and swallowing, and then either mild or absent, so 0 or 1 on voice change and tongue swelling. And then their secondary endpoint was time from either the drug or the Icatibant or the placebo administration to the symptoms improving by 1 severity grade, so going from like a 3 to a 2 or a 2 to a 1. So this is just a demographic table. They didn't have p-values here to compare the groups. Most of the groups were, as you can tell, the Icatibant and placebo were pretty evenly divided. Just a couple things to point out. Under weight, less than 75 kilograms, there were more patients in the placebo group than the Icatibant group who weighed less than 75 kilograms, presumably just by chance. And then under the type of ACE inhibitor, there were more patients in the Icatibant group who were on ramipril compared to the placebo group, but they were pretty evenly divided in terms of lisinopril. And then this is a table just looking at the other medications that patients received, so the epinephrine, the steroids, or the antihistamines, just looking at when they received them compared to when they received the study drug. So this table's a little bit confusing, but so if you look at here, all conventional medications, so 90% of patients in both groups received one of these medications at some point during the study. If you look sort of down here, time from conventional medication to study drug administration. So about 3 hours was the average time from when they got one of these medications, so like antihistamine, steroids, or epi, to when they received the either Icatibant or placebo. And then farther down, where it says time from attack onset to study drug administration, so it was about almost 8 hours, sort of even, but it was the same for Icatibant and placebo, about 8 hours from the time their symptoms started to when they received either the placebo or the Icatibant. So they found no statistically significant differences between the Icatibant and the placebo groups with either of their endpoints. And so here is just a chart from their results section. You can see the Icatibant is blue and the placebo is red. The x-axis is the time from the drug administration, and then the y-axis is when they met that sort of discharge criteria of having sort of minimal symptoms. And you can see that the lines are basically on top of each other. And 90 or more % of patients were able to meet the discharge criteria by about 8 or 9 hours. So just a couple of things. So I thought overall it was a very well done study. It was randomized, double blind. They had a fair number of patients. They didn't include severe angioedema requiring intubation. So you may be pushed in patients with really severe angioedema to kind of do something, and you can't really say anything about those patients. And they didn't specify they said they included moderately severe angioedema, but they didn't specify exactly what that meant. But the other interesting thing that was different between this study and the phase 2 study that I mentioned earlier is that in the other study they only looked at Icatibant versus patients who had received steroids and antihistamines. And here they allowed patients to get epinephrine, steroids, or antihistamines at any point, which I think was more applicable to sort of real-life scenario. I mean, most patients who do have angioedema from any cause at some point get one of those medications either in the emergency room or by medics, and so it may be hard to sort of exclude all of those patients. With that being said, they may have included patients with sort of histamine-mediated angioedema. It was unrelated to the ACE inhibitor, and it improved from some of these medications instead. But both patients, in both groups received these medications, so it shouldn't have sort of had an effect between the two groups.
So did they just in the discussion say that maybe they just administered the drug too late to have an effect?
No, I mean, so that wasn't one of the things they talked about. They did talk about sort of the steroids, antihistamines. Interestingly here, most patients had a shorter recovery time than sort of expected for ACE inhibitor-induced angioedema. So a lot of patients start to improve by about 4 hours. And so one of the things they mentioned was that possibly they sort of included patients with this histamine-mediated angioedema. They were improving from some of these other medications and not necessarily the Icatibant. But they didn't necessarily think that it takes time for patients' symptom onset to present to the emergency room to get, evaluated, and, I assume it would be a few hours before someone would, 7 hours before they would get Icatibant anyways. Maybe that's long, I don't know, but.
That strikes me as a possible explanation. They just gave the drug too late in the process.
Right. They said this at the start. Was this Shire's phase 3 study, and are they abandoning this indication now? Or?
I don't know. They didn't say, but they obviously didn't find an effect.
Then it wasn't their phase 3 study.
All right, we got one more paper to get through.
It is, they just bombed out on that.
Thanks, James.
I just have one paper that I thought I'd talk about that was kind of high impact, came out a few months ago. I think it's an interesting idea, a novel idea for sort of pathogenesis of asthma exacerbations. I'm not sure they've proved this is clinically relevant yet, but it's certainly curious. So this is from a group in London showing an idea that mitosis, which is a process I'll explain in a minute for those who don't know it, may be important in promoting type 2 inflammation in asthma, and may be part of the role of asthma exacerbations. So in effect, what they show here, and I'll summarize it, is that in mild to moderate asthmatics, they're able to show that during experimental rhinovirus infection, they can correlate the amount of double-stranded DNA in the airway with Th2 cytokines Then they moved to a mouse model and show pretty elegantly that nets appear to be necessary for type 2 inflammation during experimental RV infection and is probably responsible in part for exacerbation. They don't come around and then really prove that in humans. So for those who have not heard of this, mitosis is a process that was discovered about 15 years ago. It's sort of felt to be the third mechanism by which neutrophils help contain infection. It's an active process by which neutrophils release DNA in the form of chromatin, basically chromatin DNA complex, and granule proteins to form these physical traps. And that's what's shown on the right. This is a mouse airway infected with aspergillus. These things out here are aspergillus. And then when you zoom in, this is electron scanning microscopy. This is a DNA net basically trapped around aspergillus. So they're used to trap and degrade pathogens and sort of focus the toxic enzymes and neutrophils by limiting host tissue damage. That said, they have been implicated clearly in lupus and possibly other autoimmune diseases in part of the autoantibody formation. So what they had, this was sort of an interesting study. This is sort of a second paper the group had published from it, but they had a group of initially 28, although here they just showed 23, mild to moderate asthmatics, and they showed that in rhinovirus infection, and so they give them a RVA strain and measure nasal double-stranded DNA. They can see that in their 23 asthma compared to 11 healthy, they see a higher peak level of nasal double-stranded DNA and then sort of a persistent elevation for several days out beyond the induction of infection, which is higher than in their controls. And they specifically show that the change from baseline is highest in asthma compared to healthy. They then go on and correlate the level of double-stranded DNA here with type 2 cytokines, so IL-4, 5, and 13, and show that there's a pretty good correlation, although they cheat a little bit here. They're actually using a Spearman rather than they should use a Pearson correlation. But anyway, show that there's a relationship between the two, although they also see it in relation to interferon gamma. The argument they make is they see this relationship in both asthma and healthy, whereas the association with type 2 cytokines is only in the asthmatics. So from there, they then jump into a mouse model and they don't really come back. I'm a little bit skeptical, but nevertheless. So here they take, and Bill's not here, he could tell us more about, but basically an at-risk mouse. They sensitize the house dust mite, and then they infect with a mouse strain that can infect mice. Rhinovirus otherwise doesn't infect mice. And they look at rhinovirus versus UV inactivated rhinovirus. And they in effect show that in sensitized mice, but not non-allergic mice and non-sensitized mice, that they get a specific increase in Th2 cells only in the house dust mite sensitized mice in the context of the rhinovirus infection. And similarly, as in the humans, you see this peak in double-stranded DNA in the bronchoalveolar lavage fluid, as opposed to the nasal, is what we saw in humans. And that this is highest in RV infection in sensitized mice. You do see an elevation still, to some extent, in the non-sensitized mice during a native RV or during an RV infection. They then go on to show a number of ways why they think this is pathogenic. So they give the mice DNA pre and post rhinovirus infection and show that attenuates some of the Th2 inflammation in the lungs and also decreases the double-stranded DNA measurable in the lungs. And they do the same thing a couple other ways. Well, so first what they do is then they ask, can providing double-stranded DNA in the nose recapitulate what you would see in a rhinovirus infection? And the answer is sort of. So when they just now, without RV infection, provide double-stranded DNA, they're able to reproduce eosinophilic and lymphocytic inflammation in the lung. However, they do not get all the features of asthma, so these mice specifically do not have bronchial hyperreactivity, as you see in the sensitized mice who are given rhinovirus, and you don't see the same accumulation of Th2-specific lymphocytes. So not clear that that's sufficient to reproduce the same findings you would have with an actual rhinovirus infection. But they then, and this is where they're moving towards trying to show that, well, if you remove nets, can you sort of attenuate the asthma exacerbation? So here they specifically give an anti-neutrophil antibody to deplete neutrophils from these mice around the time of infection. Probably not the best idea in humans during infection, but nevertheless, what they're showing in this panel, and if you remove neutrophils, you remove nets. This is the native RV infection in the allergic mouse, and all of these yellow spots are nets. And without neutrophils, you don't see any net formation. They then further show this drug, which is a net inhibitor. By inhibiting neutrophil elastase, prevents the formation of nets. If that's given throughout the period pre and post inoculation, you can see at least partial attenuation of all of those sort of Th2 inflammatory findings that they had in the native RV infection. So you see a decrease in total cell infiltrate. Here, a decrease in eosinophils, lymphocytes, and Th2 cell accumulation in the lung when you give these mice a net inhibitor, and you can also then attenuate their bronchial hyperresponsiveness to methacholine in that setting. So the theory then would be, well, this may be a potential clinical approach. Of course, they don't actually go back and do anything further in humans. But despite that, it's an interesting model. This is a review that Bill Bussey then wrote in response to it, kind of showing the general idea that trying to link where neutrophilic inflammation may fit into eosinophilic and Th2 inflammation, the idea that it may be the neutrophil response, the rhinovirus, leading to net formation that plays a role in losing Th2 and then eosinophilic inflammation.
Do eosinophils do netosis?
They do, and specifically in this model, I didn't show it, but they also look at depleting eosinophils and show that that is not still. So they do a pretty good job in that mouse model showing that the nets in this case appear to be coming exclusively from neutrophils.
All right, thank you all presenters. Again, we got Alan, so the summary is don't give vitamin D and don't deplete neutrophils and don't test anybody for penicillin. Just give them the drug. All right, so Alan Kaplan is here next week. Let's treat him reasonably well. He's a Brooklyn boy. Yeah. Yeah? I don't know. You can ask.
I've seen some of his patients. Yeah, no, you'll like it.
Oh, you're there? Yeah. Didn't see that one coming.
That is the first one.
Oh, no. Well, it's good because it,
No, but I have
I would think he gave it later in the process.
I don't know where it is. So
Is that a Shire sponsor? Probably.
Oh, you've mentioned
So, they're still trying to keep reproduced indication, so it's not scratched. But,
Usually have
yeah.
something right after this.
Did not see that one.
Just this week, not usually. Yeah.
Oh, it's more than yours.
Do you,
Yeah.
yeah.
I'm going to say or email. I didn't make sure I'm going to a meeting.
Oh, okay. Oh, yeah, that's why we didn't have food line. Yeah. Do you want me to email the contract to you?
Oh, sure.
Sure.
Would that be easier probably if you want to look at it and then maybe next Tuesday we can meet? That'd be great. Perfect. Okay, thanks.
I don't know. We'll see.
Oh, pretty good.
Yeah.
It's getting there.
Take care, sir.
Pretty good. Better than your.
You gonna need it help?
I'll take a little bit of food over to the regular.
Yeah, that's good.
Break down a little bit.
I will.
Oh, I needed to ask you.
Yeah.
Zoe and I were going to work on a grant, but she's tied up.
Yeah, I think either one of us are going to come. So.
Okay, how about 9:30 at the Northgate office?
Okay.
And it'd be the same kind of class.
See you then.
Study is still going.
So I don't know if you're
yeah.
interested in not taking a look at it and seeing if that's something you want. Oh, yeah.
I mean, we currently.
Have you been really good? Is your holiday be going well?
Yeah.
I can start throwing stuff away if you want.
Okay, I'm going to take a little bit.
Did you want to take any coffee, Dr. Altman? Did you want to fill up your coffee?
Yeah, I think I will. That one must be empty.
So I'm super excited to hit all those spots.
Monday.
Another Shire representative. That study is not scratched, by the way. Like Dr. Altman pointed out, it was just given too late in the process because usually
But was that a Shire phase 3 study?
it was not a third Shire. Yes.
Oh, okay.
So just wanted to kind of answer your question, but
Yeah,
yeah,
'cause I-
Yeah.
we'll do another one announcing.
You don't have to tailor things for me.
Well, we want you to be there.
Okay, well, but I want to go to Hawaii.
Do you want me to come? I would want to be in Hawaii too.
But yeah, so
You
I'm
would,
going to
because we're
doing
actually, my family is going
and then we go to Shanghai, to Singapore, and then we hit Thailand, Cambodia, Malaysia,
You know, also we have.
Vietnam as well.
I mean, frankly, if you
And
want
then
to
we go back
Our
to
house is about midway between
yeah.
running through the body surfing beach and the Hyatt.
I'm not married at the Hyatt.
Yeah, so I can walk to the Hyatt from my house.
So it's about the same with my stepdad. So yeah.
Road called, anyway, it runs the street out
Yeah.
from close to the
busy.
walk down to the beach.
I'll be there in March, so if you need me to check on anything, let me know.
You're like,
What?
I
So, pretty much, I got kicked out of the cab in the middle of Thailand. I didn't have a data plan. I didn't know how to read any of those things. It was just really weird.
how did you get through? Like,
I found a cafe that had internet.
Emily. Oh my gosh, we need to go every single ride.
No,
Without technology.
college.
Oh yeah, like
Yeah.
I think my husband's 6. So we're in Asia. It's gonna be hysterical because he's just gonna be this
Yes.
vegan.
You gotta take everything out.
But yeah. Also, any recommendations for tonight?
There's no evidence.
I was only there for 4 days for the
gonna
wedding,
be
so
hot.
I didn't really.
Otherwise,
Yeah.
I went to
Otherwise we
I was
get in
in
trouble.
Bangkok for
we'll get in trouble with
I just
the
wanted to
FBI.
so I'm like trying to
Lying to the
like.
FBI.
It was really cool. Like, I got to see the river, some of the
Okay.
temples and
You know, if
stuff.
there's ever
But
any-
yeah, it was
Well,
real
with the cruise, we'll. Yeah, I'm sure they'll have the schedule.
Yeah.
If there's ever a time, just
You know,
between the
I'm just.
lines.
I don't see you for the holidays.
All right.
Have a good one.
This too?
Sure.
Yes.
Your signage.
Thank you.
Nah,
Dump it.
I don't know about dump it. What is
Just
it?
pound it.
What are you doing?
People out front.
Okay, give it to the.
I've missed you.
I've missed you too.
I